Start by talking about the ups and downs of tortuosity with Hady Lichaa. Hady, take it away.
It's an honor and privilege to present today. So this is my title. These are my disclosures. One of the sayings that I thought was applied to this session in the sense that, when you face complexity, you just have to dissect the problem and make it simple. And that's what I'm going to try to do in this session. This is a non-STEMI case that I had, as you see, very tortuous right coronary engaged with an Ikari 3.5 exchanged for an AL 0.75. A cyan blue would not cross, a cyan black finally crossed. A 258 balloon was inflated, and the balloon assisted technique was used with the guideliner, but the stent would not deliver. At the last turn, I was just struggling here, and I'd love to share how we resolved the case at the end of this presentation. So why is this important? Tortuosity is one of the major factors that predict success and prognosis in CTO interventions according to a contemporary multi-center registry. There's a reason why tortuosity is in the JCTO score, and that's the prognosis to and the success rate of an intervention. These are the tips that I think are helpful for interventional cardiologists when they face tortuosity. We start with access, sheath length, guide, wire, microcatheter, the anchoring balloon technique, guide extension techniques, which we'll discuss, atherectomy, which is a hot topic in tortuosity, stent characteristics, and how to do imaging. Let's start with access. Most of us think about femoral access in tortuosity, but very gradually we're shifting towards radial access with the advent of thin-walled sheath, 7 French sheath, especially with the sheathless systems, up to 8.5 French sheath and a 2.8 millimeter radial, which allows us to do complex trifurcation, bifurcation, distal left mains from a radial access with a 7 French sheath. Now, the sheath length is something that's pretty much known by the femoralists, but radialists now have long sheath that they can use for support, and this is one of the main factors to compensate for lack of support in radial access. 3 is guide catheter shape. There's to note that left-sided guides like the Ikari 3.5 guide is very good at supporting a right coronary artery intervention even more than an AL. A lot of us have AL 0.75 as one of our favorites for complex right coronary interventions. The 3D right is phenomenal for distal right coronary artery interventions by torque and counter torque. One of my favorites is also an XB RCA, which leans on the left sinus, and an XBR for very distal right bifurcation lesions. The left coronary artery, of course, the AL guides 1, 2, or 3, depending on the aortic diameter, and of course XB, EBU, and VL, depending on the brand, with 3.5 to 4.0, with 4.0 being preferred for more support. And getting to the wire, of course, we want to choose a very supportive wire, but we're going to be facing pseudo lesions with straightening of those coronaries, which can lead to ischemia. One of my favorites is the wiggle wire, and I'm going to show you a little video here where the stent is actually being advanced as the wiggle wire is being pulled back, so that push and pull that gets the stent to a distal destination. The other trick is, of course, the good old buddy wire, where you place a buddy wire which is super supportive, pushing the coronary wall away from the soft wire, which is used to deliver the stent on the soft wire, as well as the non-compliant balloon through the jailed buddy wire. Microcatheter-wise, obviously each one of us has their preferences. Caravelle is one of my favorites for tortuosity, but the angulated and dual lumen catheters are extremely helpful in 360-degree loops to get out of a branch or to wire the main vessel. Sasuke is very well known for its deliverability, as well as the supercross. The anchor balloon technique, either through a side branch or through the distal vessel, the lesion itself, through a 6 French guide, is a very good way to deliver a stent whenever we face tortuosity. Guide extension is one of the most important inventions in interventional cardiology in the last 10 to 20 years. Balloon-assisted tracking consists of advancing the guide extension over an inflated balloon shaft. Inchworming is when the guide extension is abutting the balloon, and advanced when the balloon is being deflated, one of the major techniques in getting through hard tortuosities. The balloon surfing is my personal favorite, where the balloon is used as a dilator at 2 atmospheres, a 225 balloon through a 6-French guide extension like we see in this video, where I traveled all these stents without getting stuck by advancing a 225 balloon at the tip of the guide liner, which is inflated at 2 atmospheres. So atherectomy is a hot topic. Orbital atherectomy versus rotational, always a hot debate. The orbital atherectomy offers a low profile. It can go through 6 French guide extensions, especially with the glide assist option that makes it slide. The new wire is much better than the old one to minimize pseudo lesions by minimizing bias. We always advise low speed to minimize the risk of perforation. And the advantage with orbitals, of course, you can burr on the way back, which is also an important factor to minimize perforations. Rotational atherectomy is obviously advantageous in the fact that it's front cutting, especially when you're having a hard time crossing. We don't recommend anything beyond 1.5 burrs so that risk of perforation is minimized. Dynaglide is the option to go when you get stuck. Rota floppy wire is super important to choose rather than the extra support to minimize pseudo lesions. And of course, short runs with low speed, less than 160,000 RPM. And stent choice and characteristics is very important. We often choose short stents. We overlap them when we can't deliver, like in this figure here. Over the wire if needed, but most of the new technology with the new designs of monorails have overcome that, so we're using them less and less. Inchworming a guide extension into the lesion, then unsheathing that guide extension to deliver a stent is a very popular technique, as well as the jailed wire, buddy wire, to deliver a stent over the main wire. And finally, imaging. If you have the volcano on your shelf, Philips, choose the short tip volcano. This has a 3.5 French crossing profile. OptiCross from Boston Scientific has its advantage in deliverability and lower crossing profile. And the OCT is even smaller, but a longer catheter, so which is challenging. Going back to the case, the way I resolved it is I exchanged the cyan black through a caravel to a wiggle wire, then buddy wired it with a cyan blue, then inchwormed the guide extension all the way down. We used balloon-assisted tracking to get the non-compliant balloon into the stent, and then finally ended up successful. Thank you very much for the opportunity to present.
Fantastic presentation. Thank you so much.